swallowing dysfunction. Certainly coughing, choking, gagging during feeds is a very easy one to come up with. If the child has noisy or wet respirations associated with feeding, you're suspicious that they're not clearing things well from the hypopharynx. Some physiologic signs that you're looking for, potentially some increased respiratory rate, oxygen desaturations, color changes associated with feeding. If the child has a tracheotomy tube in place, it's very easy. If you see stained secretions coming through the tracheotomy tube, the only way out there is through aspiration. So some of the decision making that we have is, where do we go from here? Is this a child that needs an evaluation by a full multidisciplinary team, or is this a straightforward child that we can work with in individual therapy and see how they progress? Is this a child that we need further instrumental tests on before we make any specific recommendations? And the most common instrumental exams are the video fluoroscopic swallow study, the X-ray study, or FEES, the fibroendoscopic evaluation of swallowing. The pediatric VSS is a radiographic study of the child ingests barium. It is a very good study for looking at anatomy. We can look at function as well. It's a quantitative evaluation where you can see how much food material is ingested, how much is cleared with the swallows, how good hyoid elevation is there aspiration, to what extent is the aspiration, and what's the function of the esophagus as well. So the video fluoroscopic swallow study, you can also look at how you can work with the child to improve things. There's some postural changes that you can do. You can do some compensatory strategies with flow rate or viscosity. And if the child's older and can follow verbal cues and instructions, you can try different maneuvers to see if that's going to improve things as well. This is just two examples of video fluoroscopic swallow studies. Child on the left has a little bit of delay in swallow, but overall it's a pretty normal swallow, in contrast to the patient on the right who has a lot of hypopharyngeal and oropharyngeal discoordination. The child is trying to swallow, but is having a tremendous amount of difficulty in clearing material from the hypopharynx. The fibroendoscopic evaluation of swallowing was developed by Susan Langmore. We adapted it to the pediatric age group in 1993. The protocol that we developed for infants and children is very similar to the one that Susan Langmore developed for adults, but it's age appropriate for what the patients can take. We can bring our endoscopic evaluation of swallowing to the bedside. We can go to the newborn ICU, to the pediatric ICUs. It's ideal for breastfeeding infants who will not take any food material from a bottle. And we've had no events and many thousands of FEES exams. I feel that in pediatric FEES, it's ideal to have this be a collaborative evaluation between speech pathology and a physician, in our case, otolaryngology. The focus of FEES is really on the assessment of the anatomy and function as well as sensation. It gives us clear definition of the anatomy down to the vocal folds. We get some idea of hypopharyngeal sensitivity. We can look at secretion management, which is an indirect measure of secretion of sensitivity. If the child is having a lot of secretions in the hypopharynx, it tends to decrease their sensory awareness and increases the risk of aspiration. So we can get an overall evaluation of swallowing safety with the FEES. These are just some examples of what you can see abnormal FEES exams. On the left, you can see some spillage of material over the tongue base is into the piriform sinus, occasionally penetrating into the larynx. The child kind of blows secretions out. On the top right, this is frank aspiration. The child has secretions that are falling into the airway, and the child's really not making much response to these secretions falling into the airway. And the bottom example is just a tremendous amount of residue, and you can also have residue falling into the airway and being aspirated. So the utility of fees is really focusing on airway protection. We can identify some anatomic abnormalities. In the pediatric age group, many of these children never had a formal assessment of airway structures. It's different in the adult population who have had 50 years of normal swallowing and then something suddenly changes. In the pediatric age group, we frequently find anatomic problems. In the adult world, you rarely find it. So that's where there's a little difference in shift of priorities to assess structural aspects in the pediatric group. With fees, we can do a rough sensory threshold. We can look at spontaneous swallows to clear secretions. Because there's no radiation, there's no time limit on our fees exams. And it's very good for interval and follow-up evaluations. The child may have already had an X-ray study, and you just need to know if it's safe to push forward. And a fees exam can often give you that information without having to radiate the child again. With fees, we can still do various compensation techniques, same as for the video fluoroscopic swallow study. And in the older children, you can also do the verbal cueing. You can alternate liquids with solids. You can try some of the chin tuck and head tip maneuvers. So some of the outcomes of your feeding evaluation is really to determine, is it safe to feed this child orally? If it is safe, how are we going to feed this child orally? And are there any interventions we can take to improve the safety of swallowing? Are there any medical interventions that we need to make prior to starting an intensive feeding program? Are there any surgical interventions necessary beforehand? We just don't want to miss any medical or structural problems that need to be addressed. The child will never be able to feed normally unless you address those. So in conclusion, when you see a child coming into your office with significant feeding issues, what not to do, you really don't want to manage complex patients with feeding issues alone. It's really ideal to get these complex patients into a multidisciplinary team environment. You need multiple eyes with multiple different disciplines coming at the child in different ways to come up with an effective treatment strategy. What must be done, you really need to do a full assessment of swallowing safety, and you also need longitudinal management because these children change over time and you need to modify your treatment over time as well. You want to make sure that you adequately treat any underlying medical or structural problems before getting the child into just straight therapy. And don't forget to look for some rare conditions as well, because they can have very significant impact on swallowing safety. All right. Thank you very much.
Thank you so much, Paul, for the wonderful overview outlining of the various factors.
Raman sir, we cannot hear you.
Can you hear me now?
Yeah, voice is very weak.
Okay.
Still, little better now. Yeah.
No, not good.
Not good, not good.
How's it now? Better?
Little better, but not good yet.
How's it now?
It's the
Little
same,
better.
but not good.
Okay. Maybe can you just take over while I sort this out?
It's okay, sir. It's okay.
It's back, it's back.
Better. Okay, must be something to do with the Wi-Fi. Okay, Paul, that was a wonderful overview of the problems and your stress on interdisciplinary group to take care of all these multifactorial problems which lead to following problems in children. And what we'll do now is we'll just go for a quick set of comments from our panelists, and we can ask maybe Deepak, would you like to comment on certain or underline?
Yeah, I'll just say a few words about both the speakers first. Paul has been my mentor, one of the smartest guy I know, and also the most humble and a wonderful human being. And he's the one who basically introduced FEES to the pediatric world and popularized it. And FEES is where it is because of Paul and his team, Claire Miller. So it's very important that we have that in our tool. And one of the things from my practice point of view, it's very easy for us to say, look at all the airway surgery and think that that's big. But one of the most satisfying thing is a lot of these parents are very frustrated because they've gone multiple places. They don't know where to get to. And it is one of the most satisfying things to take care of, where you make someone swallow better. So apart from doing surgeries, this is a very important aspect of taking care of some of these kids. Next thing about Christina. Christina is the backbone of our swallowing team. So for any team, your speech pathologist is the core person who will put everything together. She works with me every Monday and she keeps me in place. So it's very important to develop that relationship with your speech pathologist because as a team, you'll make many lives better.
Thank you, Deepak. And you stole some of the words out of my mouth. Paul has been a major pillar or support for our charitable airway program, which we've been running for the last 19 years. It's actually surprising that we were able to do this in a for-profit hospital, the Manipal Hospital, where all the children are treated free of cost. But then that we wanted to bring up the standard. So that's the reason we sought international collaboration. And that's the reason we've been gradually stepping up a standard of our care, hopefully. And people like Paul, who've been coming year after year and helping us set up our center. We're very grateful to you, Paul, and look forward to your support in future also, and inspire young ENT surgeons to take up airway-related issues. And any other comment from Ajoy or Dr. Sohit is here? Sohit?
Yeah, he's here.
Sohit, you want to say something?
I don't think I can add anything to what Dr. Wilkins said. Just to emphasize a couple of points, which Deepak also mentioned, is that these are one of the most complex patients you're going to see, and it's not a one-man's job to deal with pediatric dysphagia. So it's a multidisciplinary approach, and I think every airway program needs to have a solid swallowing component to their whole aerodigestive program. One of the things just to emphasize is FEES is a very, it's just a beautiful study. One of the very important factors about FEES is the parents actually get to see how the baby is swallowing, and that's very satisfying for the mom, as Deepak mentioned. You really make a huge quality of life difference once the child can swallow properly. The thing to look for in these patients is also a double pathology. So I feel FEES and BFSs are both complementary to each other. We have cases where kids had laryngomalacia but also had underlying cricopharyngeal aplasia as well. So there'll be factors which you might not pick up on a FEES, and then they eventually get BFSs and you pick up a secondary swallowing pathology in them as well. And more importantly is the behavioral component in feeding. As ENTs, we are usually focused on the structural component and we try to fix the structural component. But then there's this whole behavioral component associated with pediatric dysphagia, which needs more help from us. And many of these behavioral issues are related to the structural issues. And when you correct the structural issues, the behavioral components tend to get corrected by themselves. So I think this was just awesome. That was great. So thank you.
Thank you very much for your comments, Sohit. I will move to the next talk by Christina Rapazzo. Welcome. Thank you very much for accepting our invitation. She's going to talk about the SLB perspective to swallowing issues in children.
Yeah.
Good morning. Thank you so much for the invitation. I'm very humbled to be here and to be speaking with Paul Wilking. So thank you, Paul, for your presentation, and Dr. Mehta and everyone in India for your invitation. So I'll be taking the perspective of a speech pathologist. Hope you can see my screen. Does it look okay?
Looks good. Your voice is clear.
Perfect. Perfect. Thank you. My voice sound okay?
Perfect.
Okay, perfect. Okay, so briefly, I want to make sure that we're all on the same page. Now, I want to take a quick overview of swallowing and how we sort of talk about it to make sure that we are using the same terminology. So we know that swallowing is extremely complex, but for ease of discussion, what we've done as professions and scientists, clinical scientists, is we divide the swallow into three sort of parts, three phases. So we talk about the oral phase, the pharyngeal phase, and the esophageal phase. And when I was trained in school, we divided the oral phase into two parts, oral preparatory and oral transit. I think that now they're kind of going down to just three, but there are times where they'll talk about four phases. So the oral preparatory phase, and I really want to emphasize this phase a lot because I think that it can get overlooked. If there are deficits in the oral phase, it can lead to deficits in the pharyngeal phase. It's all one sort of swallowing pattern. We divide it, but one phase influences the other phase. So it's how the infant or the child expresses liquid from the bottle or from a straw or from a cup, and then how the child organizes or informs a bolus. Very, very important, whether it be a thin liquid bolus or a puree bolus. And with regard to solid, how do they chew? Does that 2-year-old chew well enough to break down that cookie or that pasta, or do they swallow it whole? Could the gagging and choking be simply a chewing issue at heart? Again, so we're looking for some of these abilities in the oral phase and how they impact the pharyngeal phase. And we look at them through a developmental phase. And so as Dr. Wilging discussed, there is always a developmental overlay, but there may be structural issues underlying or neuro issues underlying. So it can be somewhat complicated, but we have to make sure that we know normal development to know what to expect at what ages. Oral transit phase is when we're transferring the bolus from the oral cavity into the pharynx, and it can last to up to about 1 second or so. The bolus is propelled back into the pharynx. The soft palate to close off the nasopharynx. The pharyngeal phase of the swallow. So there's really specific components here. We see most of the components that I'm highlighting here in the video fluoroscopic swallow study, but the velum does elevate and close. The hyoid moves forward. Tongue base retracts. We have elevation of the larynx. We have the epiglottis tipping downward. We have the true and false vocal folds closing, and we have initiation of pharyngeal constriction from top to bottom. And then we have the UES relaxing and opening based on these movement patterns. So very complex. It happens within about 1 second, the pharyngeal swallow. So the timing has to be right. All these movements have to be totally coordinated for it to come out smoothly. Let me move this over. One thing I do want to highlight or mention is that there's redundancy in the system, which is a wonderful thing for us. So we have multiple levels of airway protection. So if one level airway protection is faulty, for instance, we have true vocal hold, paralysis, or paresis, but if we have the other levels of airway protection that are intact or functioning appropriately, we can still compensate and protect our airway. Inversely, if we have an impairment in the pharyngeal swallow where our swallow is delayed in the initiation, and we have some laryngeal penetration because of that, if our final level of airway protection is intact, the true vocal folds, then we can still protect our airway to a certain extent. Okay. And lastly is the esophageal phase. And so that portion is best viewed through a video fluoroscopic swallow study. And from a speech pathology standpoint, we tend to emphasize the function of the UES. Does it relax, and is it opened based on functions from the hypopharynx? So the tongue base retracting, the pharyngeal constrictors constricting and pushing the bolus into the UES, the hyoid elevating, bringing the larynx forward, therefore opening the UES for a nice clearance of the bolus through the upper esophageal sphincter. So I want to just show a quick normal infant swallow. And so what we're looking for is rhythmicity. We're looking for the suck, swallow, clear, suck, swallow, clear. We're looking for fast and smooth and effortless swallowing. Here we go. And it takes this baby just a second, but then she'll go to suck, swallow. Here she goes. Suck, swallow, suck, swallow, suck, swallow, suck, swallow, suck, swallow, suck, swallow. That's fast. It's rhythmical. It looks like it's effortless. There's no pharyngeal residue or anything left in the pharynx post-swallow. You can kind of snap your finger to it. And she's very patterned. So every time she sucks once, she swallows, suck, swallow, suck, swallow. There is always a range of normal. And so even up to 2 or 3 sucks per swallow is normal. But we want fast, effortless swallowing. Okay. Here's what I call a functional swallow. You'll see in the oral phase, the nipple will kind of slide in and out. But you do have functional airway in this swallow. And if you look at the pharynx here, again, into the esophagus quickly, there's no pharyngeal residue. You see that nipple kind of sliding in and out because this child has an underlying disorder, but very functional. And that's one thing too that I want to highlight with some of our children with genetic disorders. We have to think functionally for them, or severe neurologic disorders, think functionally. And how can we get them eating functionally rather than essentially perfect? Okay, so we talked a little bit about normal swallowing or what to expect. And then so we go to our assessment. What do we have? What are our options? We have non-instrumental options, which is the clinical swallow evaluation. And then we have instrumental options, which is the video fluoroscopic swallow study, fees. So I want to begin with the clinical swallow evaluation, and we'll talk about infants and toddlers. Before we talk about the infants and toddlers, I want to briefly highlight infant sucking. And so infants are geared to feed, that they need that to survive. So oral anatomy, as you all know, as sort of oral anatomy experts, is geared toward this. So the tongue occupies most of the mouth, and what does that do? It helps stabilize the nipple. The sucking pads laterally, they help stabilize the nipple as well. That larynx higher in the neck for added airway protection. And here we go. Let's see. I want to talk about development well with regard to suction, very young infants. So suction, or the ability to express that liquid from the nipple, is a developmental process. So for any of you working in the NICU or with very young infants, there is a developmental phase that comes through. So it begins at about 32 weeks. It's weak. But then it matures and develops well at about 36 weeks or so. So for instance, if you put a pacifier in the mouth at 34 weeks, you will get some suction, but you can probably pull it out rather easily. By 36, 37 weeks, you should have a good suction. If you have a term infant who's in your office and they're 3-week-old and they can't produce suction on a pacifier, that kind of concerns me. I have to look at anatomy. And then if that's okay, then you look at neurology, because why can't they elevate that palate to get good suction? But I want to highlight that it is a normal developmental process that about 36, 37 weeks should be there. So how does an infant suck? There are 2 phases to sucking. There's positive pressure and negative pressure. The positive pressure, we call it compression. So it's basically created by the jaw or tongue stabilizing the nipple and kind of pinching or compressing it. That's the positive pressure phase of the. And the negative pressure is where that suction that draws the liquid out of the nipple. So positive and negative pressure working, alternating to express liquid from a bottle. Critical component for sucking, and it's what makes babies efficient feeders. And again, if your infant is a term infant in your office and doesn't have that suction component, you want to think about structure. That's intact. By structure, I mean soft palate. Can that soft palate elevate? And then if not, possibly neuro. Why is that soft palate not elevating? Normal nutritive sucking is about 1 per second. So I tell people you can kind of snap to it. 1 Mississippi, 2 Mississippi, 3 Mississippi. That's nutritive sucking. That means sucking on a bottle, not pacifier sucking. Pacifier sucking is non-nutritive sucking, and it's typically a little faster, usually about 2 sucks per second. Nutritive sucking should be rhythmical, and we have what we call a suck-swallow ratio. So typical is 1 to 3 to 1. So they may suck once and swallow, or they may suck twice to get enough liquid out and swallow. We believe the range to normal is about 3 to 1. Okay. So if your infant is sucking 4 or 5 to get the liquid out, we have to start to problem solve. Could it be the nipple? Is it too slow? Could it be the liquid that's in there, or what's going on with the baby? But we look for an overall pattern. And once again, I want to highlight kind of normal fast rhythmical sucking, and we're going, there she goes, suck, swallow, suck, swallow, suck, swallow. So this suck swallow ratio is 1-to-1 with prompt swallow, good pharyngeal clearance, good airway protection, rhythmical, just this is kind of what you want to see. And I'm highlighting this because you'll see some videos where an infant doesn't do this and you can see the difference. Okay, and lastly, I want to bring up something that Dr. Wilging brought up is coordination, very important. So you may have the strongest pacifier, you may be able to express the liquid, but if you can't coordinate the suck, swallow, breathe triad for various reasons, it's just not going to go well for that baby. So they have to be able to feed over a 20, maybe even 30-minute period, coordinate that ability to suck, swallow, breathe. So the suck, and when they swallow, they sort of do that swallow apnea. After that, they exhale and they go to that next suck. And as they're sucking, they intake that air. So suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. Very important. And this in an infant, should be sort of well coordinated and mature by about, between 37 and 40 weeks. Again, if they're a term baby in your office, clearly it should be there. So back to our clinical swallow evaluation for infants, what do we look at? So we look at the oral phase, we look at what nipple they're taking, what bottle flow rate, how they're being fed, what position they're being fed in. We look at their rooting or their latch. Is there a nice, good root? Can they latch and form a seal around that nipple? Okay. Is there a lot of anterior spillage, or can they keep the liquid in their mouth? We try to look at their suck swallow ratio, and you can look at this clinically. It takes a little bit more of a tuned eye, but you can see if they're sucking, and there's no sort of swallow after that, or if you see that suck swallow. You can look at rhythmicity. You look at jaw movement, you look at rhythmicity. You look at what we call sucking burst. A sucking burst is how long that baby goes on to swallow, how long the suck, swallow, breathe is before they stop to take a little bit of a break. Okay. And again, you're looking at coordination of the suck, swallow, breathe. Pharyngally, I also want to enforce that we can suspect a pharyngeal disorder based on what we see or hear. We suspect it, but clinical evaluations can't really diagnose them or give you much information. So we're looking at the same things: increased breathing, increased respiratory rate. Do we hear what could be pharyngeal wetness? Do we hear laryngeal wetness when they voice after they swallow? Avert coughing, choking, gulping, congestion, anything that looks like this isn't going smoothly, then we begin to suspect a pharyngeal swallow impairment. But there is value to the clinical swallow evaluation because it gives you some of the oral phase. It gives you the information about the dynamic of the mother-child feeding and the parent-child feeding. So there is value to the clinical swallow evaluation. It's just very limited with regard to pharyngeal swallow. Now, an older child, a toddler and up, we're looking at labial seal closure around the spoon, around the fork, around the straw, on the cup. We're trying to glean into bolus formation or control. Does it spill out the mouth, or does it look like they're kind of forming a bolus? And can they transfer it? And after they transfer it, is there still food left in the mouth? You can ask them to open their mouth to see if there's any residue in there, or is it pretty clear? And for children, especially 18 months or 14 months and up, we really look at mastication skills very well. I find that many of these children, they're delayed in many ways, and one of them is their mastication skills. So in order to chew, you have to put the solid on your tongue, but you have to lateralize to the molar table. And this is really important. The tongue has to push the solid food over to where the molars would be, even if there's no molars there yet from a developmental standpoint, but to the jaw. And then that's where with the jaw motion, the up and down breaks it down. And then the tongue, again, brings it back to the center of the mouth and pushes it back to swallow. So that lateralization to the molar table is key. Oftentimes, it's not so much the jaw that's a problem, but it's the tongue. So again, the tongue and swallowing is so important to form a bolus, control the bolus, and push it back. And just as with infants, what we look for toddlers and up is any wetness, congestion, coughing, choking, repeated respiratory infections that we're quite not sure where they're coming from. And if we suspect these things, then we certainly do then recommend an instrumental evaluation of swallowing. Back to limitations of the clinical swallow evaluation. So it will only give you some information on the oral ability. So I said about the transfer into the pharynx, you can kind of gauge that it's okay We measure those instrumentally by where the bolus sort of passes the level of the ramus from the transfer to that. That's what we look at in terms of milliseconds. So, but we can kind of gauge the swallow study. It gives you no information on swallow physiology, pharyngeal swallow physiology. We can only suspect it, and it certainly cannot detect silent aspiration. And I want to mention briefly a study by the team of Boston Children, so silent aspiration, who's at risk. And this study kind of highlights what we've seen clinically for years, or reinforces kind of what we've seen clinically for years, in that when children do aspirate, they tend to be silent aspirators. So on this study, they looked at about 1,000 video swallow studies, 1,200, I believe, and 440 patients aspirated in their study. Of those that aspirated, of the 440, 393 did so silently, and about 47 did so with a cough. So these are the numbers up here. Silent aspiration, and 40 was overt. By overt, they mean they gave some sort of clue indication, either by a cough or throat clear. Okay, I just highlighted here two populations, laryngomalacia and Down syndrome. I just picked two. So in the laryngomalacia population, they had 59 aspirators, 56 of those silent, and 3 of them did give a cough or strong throat clear. Again, Down syndrome, you'd expect silent aspiration there because it's neuro. 30 total aspirators, 27 were silent, 3 coughed. So again, just highlighting the fact that instrumental evaluations are the only way really to detect silent aspiration. Okay, so what exams do we have? We said we had the video fluoroscopic swallow study as one of our choices. So the purpose is to describe the oral and pharyngeal swallow physiology. We want to look at where the breakdown in the swallow is. If they are having swallow issues, what's happening? Is it the oral phase primarily? Is there poor bolus formation and control when it's slipping back to the pharynx? Or is that portion pretty intact? And when it gets to the pharynx, is there no swallow trigger, or is there a late swallow trigger? It does not rule out aspiration, because sometimes we'll get a referral to rule out aspiration. You know, swallowing is so dynamic that we may get a child who truly does have aspiration events, and we just didn't capture one on the swallow study. Having had said, what we did capture was swallow physiology that showed a delayed swallow, or a pretty persistent laryngeal penetration, or really poor oral control that we can suspect or say, you know what, it probably does happen at home. I can see how mom reports coughing and choking, because in the swallow study, though we didn't capture the aspiration event, we saw physiology that was poor or poorly timed swallowing. And again, we do more than just chase aspiration. We look at physiology. And one thing too that I want to emphasize is that it's a guide for a treatment plan. So it is interventional. What can we do to make the swallow better and keep this child feeding? So we want to keep children eating by mouth. That's our goal. We want them eating by mouth as functionally as best as they can. So with regard to speech pathology, we tend to microanalyze these studies, and we look at lots of little things. So we look at labial seal, anterior spillage. Does the liquid or food leak out the lips? Again, back to the sucking skills in these babies. So rate of sucking, effectiveness of sucking, rhythmicity, coordination. We look at all this during the swallow study. Bolus control formation. Is a bolus gathered in a cohesive manner? Or is it spread all over the tongue, slipping out the mouth, in the lateral cavities of the mouth? Where is that bolus? If you see up here, you see a nice black circle. You want this, the bolus. You want a controlled bolus, okay? Posterior oral containment. So sometimes we'll talk about premature spillage. So if your posterior oral containment, or the tongue inability to control the bolus is poor, then it will spill prematurely into the pharynx. So right over here, we contain the bolus in our mouth by what we call the lingual velar seal. So the tongue comes up, contacts the velum, and it prevents this bolus from slipping back into the pharynx until the person deliberately does so. So very important. You'll see it too in fees when you see liquid sort of fall into the pharynx prematurely. Bolus transport. So can the tongue tip come up, move back, and transport that into the pharynx briskly? So here is a video swallow study where it isn't as precise and as well coordinated as previous infant. You can already kind of tell. So there's kind of there's tongue bunching here. He's kind of holding his tongue up. The nipple can hardly get in. He has multiple lingual motions. We have a very small bolus being expressed. We have oral residue on the tongue. We have anterior spillage. So very different from that other infant. We have the lower pharyngeal residue here. So very inefficient, multiple lingual pumping noted to express the nipple residue, just quite different from the one that we saw a while ago. Okay. Initiation of the pharyngeal swallow response. So now we're looking at the pharynx. So where is the bolus? Where is the liquid before we start to see the pharyngeal swallow begin? We always document that in our notes. The further in to the pharynx that it gets, the further deeper, the worse the sense or the higher the risk, right? So we kind of want to see molecular swallow for most infants or before. So if it gets into the lateral channels or in the piriform sinuses, and if it sits there or dwells there, then we're a little more concerned. Okay, soft palate elevation. Does the soft palate elevate to close off the nasopharynx? We look at epiglottic inversion. Of course, it's one of our levels of airway protection, and it is a little bit variable based on age. On a young infant, you'll see different than you will for a teenager or a 10-year-old. The 10-year-old will be a little more adult-like and will see complete and total inversion. Anterior hyoid excursion with the swallow study, very important. Remember, that goes up, brings your larynx up, helps open up your UES, and gets your sort of your larynx out of the way to protect it. Older kids, again, we see this on the video swallow study. We don't see it on young kids because you can't even see the hyoid. And remember, in an infant, the larynx is already higher up in the neck to protect the airway. Laryngeal elevation, we'll comment on all of this. And what about pharyngeal stripping? So that is sort of a lateral view of constriction, and it starts from top to bottom. And it looks at without the constriction, what happens is that you'll end up with a lot of pharyngeal residue. So you don't want that. That sort of pushes the bolus down into the UES and clears the pharynx. So very important to have a good pharyngeal stripping wave. Okay, these are some still images. Again, just to show you, here is the nipple. Here is residue on the tongue. Here's residue on your tongue base. Here's your vallecula. Here are your piriform sinuses. Here is your posterior pharyngeal wall with black residue. And up here as well, kind of entering the nasopharynx right here. This is your NG tube. Here you see the nipple is already out of the mouth, but you have some residuals here. You have residuals on the tongue. You have it on the tongue base, your vallecula, your piriform sinuses. Here is a trace of tracheal aspiration. Here's posterior pharyngeal wall and up into the nose. So again, a very sort of disordered, dysfunctional swallow compared especially to that very first baby, where after they swallowed, there was no black left in the pharynx or the oral cavity. So penetration versus tracheal aspiration, I want to make sure we know the difference. And certainly penetration is when it enters the larynx, but does not fall below the true vocal folds, and tracheal aspiration is below the true vocal folds. And this is an example of some deep pharyngeal penetration, kind of a hook-like going over the rhythms, getting really, really close. And we do, clinically, we do differentiate between what we call deep penetration, shallow penetration. If I see shallow penetration once or twice in the swallow study, it doesn't concern me very much. But if I'm seeing deep penetration and it's consistent, then I can assume or be a little more concerned about that patient, especially if they're having recurrent respiratory issues. So back to aspiration and speech pathology. Oftentimes when we see aspiration on a video swallow study, we talk about the timing of the aspiration. And that's really important because that gives you insight as to what the problem is or why they're aspirating. And again, if we capture aspiration on the video swallow study, we want to know why, what's going on, where is the breakdown in the swallow, so that maybe we can come up with interventions to offset that. So with regard to timing, we talk about before, during, or after the swallow. So does the bolus enter the airway before the pharyngeal swallow is triggered? Does it enter at the time the swallow is being triggered and started? Or is it after the swallow? So the swallow has been completed, and then you see contrast fall into the airway. Okay, so here is on this video, you will see aspiration before the swallow. So the liquid will go back into the pharynx. Here it is right here. We'll go back here. It falls into the airway, and then you see the pharynx begin that pharyngeal swallow. Let's see if we can see it. And there. You see how it hit the piriform sinus, if I can stop it or not. Okay, so here is the bolus in the vallecula. Here's piriform sinus. You'll see it dip over. The swallow hasn't started, so the bolus has reached the piriform sinus before the pharyngeal swallow has sort of initiated. And what happens then is the bolus falls into the airway, and then there's a swallow. It's hard to see the hyoid, but here it is on this video, and you already have liquid in the airway. So you see that, okay. And so usually aspiration before the swallow usually means there's a delayed swallow trigger, as was the case with that patient. So this is aspiration during the swallow. The aspiration event on this exam is a little bit more faint, so it's harder to see, but the contrast enters the airway at the same time the swallow is triggered. So did you see it right there? Let me see if I can go back. Let me see. There's a little bit right there. Again, the timing. There we go. And our last study shows aspiration after the swallow, residuals of nectar, so of a thicker liquid. We'll talk about thicker liquids a little bit later, but we already have some residue here on the tongue, on your tongue base. Here's your vallecula, here's your soft palate, here's your NG2 going this way. So swallows, there you'll see the residuals in the piriform sinus, then kind of just dribble over into the airway. See, there it is. You see that? There's two aspiration events on this exam. The one I'm highlighting is the one after the swallow, but then there's another one that's actually during the swallow. So your patient can do several things. Your patient can aspirate during the swallow and aspirate after the swallow. Replay it, there it is. And then the second one is during the swallow. So you have that posterior line. And we'll talk about thickened liquids in general. For the most part, we want to make sure that we do instrumentation before thickening any liquid, because you could have a patient who actually can do worse on the thickened liquid. I really want to highlight this video here. I have a few more videos embedded into the presentation. They have different they just show different examples. Again, this is an infant who's sucking. Again, back to the previous first example, you see how very little is drawn out of the nipple. There's a little bit more. Multiple tongue movements are needed. The bolus is small. It's just not as coordinated or rhythmical as that very first example. This one is a little bit more functional, a little better. There's some rhythmicity there. A little bit of residue on that tongue-based vallecula on the tongue as well. Oh, okay. Here is an example of an infant with an open, unrepaired cleft palate. Again, this is what you will get. It's normal to get this in an unrepaired cleft palate. And as long as you modify the nipple or have a nipple that is spiritual with cleft palates, they should be able to feed functionally, as long as that's all that is their problem. So again, this is normal to expect in an infant with an unrepaired cleft palate. And all we do is educate the bottle, we give them the appropriate bottle, and if there's nothing else involved with this patient, they should be able to feed. Let's see if we have next slide. This is an example of a patient who has very poor oral skills and doesn't chew and swallows the bolus essentially whole. This patient is a little bit older, but they have developmental delays, and so neuromuscular delays as well. So you will see them. They will move. She's going to move. Here it is. It's in the mouth. Those are her little earrings. And essentially, boom, there it goes down. And there's piecemeal deglutition, means you need it twice to do it. Here's another one again here. You'll see the next. She has an anterior spillage. So her oral phase, really, and she swallows that whole. You see that? Right here. Swallows it whole. And again, her pharyngeal phase, I mean, her trigger wasn't that late at all. It was look pretty good. There's no pharyngeal residue left. Oh, here, let's see if it comes back. Here it is. And She's mashing it with her, she's mashing it here, and it's on her tongue. She's kind of fiddling with it. She's not lateralizing the bolus, so she's using her tongue and hard palate to mash it and push it down. So again, it's the oral phase here that we'd have to work on, this chewing, to make sure she has no more of those choking spells. She's having choking spells with solids. Her pharyngeal phase, there's no residue. There was no penetration or aspiration. This actually was somewhat functional. We had to work on the mouth or just cut up the solid, depend on her prognosis. And last but not least, there's, I'm sorry?
No, don't worry, go ahead.
Okay.
Go ahead.
Okay, so the last video swallow study, this is a little more impaired swallow physiology. And so you already see contrast here, all in that posterior pharyngeal wall, here up the nose, tongue base, follicular, piriform sinuses. There's the next bolus coming through. This patient has 22q11, so you'll see in a more impaired, involved swallow. He doesn't clear the, see that pauses up, minimal amounts clear into the UES, into the esophagus. She's struggling, really struggling to push back and swallow. And you have that residue. Again, so a little more impaired swallowing with this patient. Really struggling there. Okay, so that's our sort of portion on the video fluoroscopic swallow study. And we can ask questions at the end of the presentation. I want to briefly talk about fees, as Dr. Wilging mentioned, the purposes of it, why we do them. And I also want to emphasize that I truly believe they're complementary exams, video fluoroscopic swallow study and fees, they're complementing each other. They give you different information. And for many children, we perform both. And for some, we only do one. But I would say the vast majority of our more complex patients have probably had both exams. Okay, and there's a wonderful paper out by Dr. Wilging and Claire Miller on their experience at Cincinnati Children's for the past 25 years. Good read if you have time. Again, it looks at anatomy, movement, sensation. I'm going to kind of go through this quickly as Dr. Wilging covered it. And I just have a few examples of fees, kind of a normal fee. Here's contrast between fees and video fluoroscopic swallow study. Again, with fees, we have no time limit, so it's wonderful. It's portable. You can see secretions. You get a beautiful view of the structures. The hardest part, I think, from my standpoint, is sometimes patient compliance, but we have that also in video swallow study. Even though if the video swallow study, there is nothing in the nose, I think sometimes just the equipment can kind of scare off some of the children, and we sit them in the chair and the machine starts to kind of move, make some clicking sounds. And sometimes that is hard, especially for children with developmental delays who don't quite understand what's happening. Fees scoring or analysis, again, you don't get much of the oral fees, but you can see some of that clinically before or after the exam. You can do some more clinical assessment of that, but you do get some good information about the pharyngeal swallow and airway protection. So you can see where the swallow is triggered, how the airway closes, and any residuals especially. It's very good, in my opinion, for looking at pharyngeal residuals. Okay, again, you know your landmarks, that's ENTs, your follicular lateral channels, piriform sinuses. Here we go, folds. This is real important for fees. And I make my red circle as well as I could, but this is kind of the laryngeal rim, which is kind of what we look really carefully on during fees. How does that bolus reach the rim? And if so, what is the response? Again, here's for this point and beneath this point, we'd call it tracheal aspiration. Here we'd call it laryngeal penetration on that rim. Okay. I have an adolescent here. I'm going to skip the normal adult, but I have an adolescent here if you want to see this. I'm going to kind of forward it to a few minutes here. Start playing it, but I'm going to forward it to the point where I see, let me see. She was a normal. You see secretions right away. I mean, just secretions. And we expected to see more secretions further down, but here we are in the soft palate. And she did have PI, she did have hypernasal speech. She was normal prior. Here we are. But, you know, I expected to see more secretions down there, but we didn't. Okay. I'm going to skip the part where I think we start to feed. It may not let me stop. So I'm gonna have to just play it. I'll try one more time. Here we go. Here we go. We should start here. See some puree coming up, and we just dye this. And this is an outpatient. Here we go. There's the in the vallecula heading towards the lateral channel on patient's left side. There we are, sinus, and there's the swallow. We have a little bit on our scope. So again, you'll see some here. Here's your vallecula, and there we are. She swallows, there she goes. There we go. This is a puree consistency. And I'm going to forward to 318, where you will see thickened liquid. It's green. There we go. Here, molecular swallow. She is. And right about 318, you will, oh, I think we missed it. Hold on, I'll go back real quick. You'll see liquid go right over the airway. Okay, I'm not going to touch it. Let's see if it does it. There it goes. I don't know if you saw that briefly. There was a green that entered the larynx just before at 3 minutes and 18 seconds. Okay, a normal infant fee. So this is what we call, not add dye to this. I thought that the formula was wide enough. You really don't see the bolus, right? You don't see the bolus because the trigger is so quick that the baby triggers the swallow before the vallecula. There's no pharyngeal residue. And so you have essentially see most of the bolus at all. Occasionally you will, but suck, swallow, suck, wide out, suck, wide out, suck, swallow, suck, swallow. So during the swallow, you're getting that wide out, suck, wide out. It's rhythmical, just like that video swallow study was, where you could tap to it. Suck, swallow, suck, swallow, suck, swallow, suck, swallow. And then we get a little blur there. So again, that's a sort of a more normal infant. And I'm going to go on to the next patient. This is a 4-month-old and a terrible swallow by any means, but just in contrast to the first one, you will see the formula in the pharynx. And this baby came in for noisy feeding, noisy breathing. Here we go. A little upset there, but they will go down, they'll feed. There we go. There's their feeding. Suck, swallow, suck, swallow. Really, rhythmicity is not bad. Suck, swallow. And then you start to see a little of the formula, like you see that, the infant formula. And then you'll start to see it reach the piriform sinuses onto the laryngeal rim in a bit. There we go. See that? That white liquid going in. Here we are again. There we are again. So a little different from there we are again. A little different from the previous fees. There we are again. You see that onto the retinoids than the previous fees, just a contrast. Okay. And lastly, I want to talk about intervention strategies just briefly. And Dr. Mehta asked me to highlight thickening, a little bit about thickening. So with regard to intervention as speech pathologists, we have rehabilitation strategies, and this definitely works for children who are a little older and sort of lost their swallow, and we have to reteach their swallow. And we also have various feeding tools, techniques we can use, kind of oral motor therapy, and look at different cups and vessels and nipples to see what we can do. And then we can also sort of vary the consistency as a sort of a temporary band-aid for the problem to get the child feeding as functionally as possible, and then tweaking and working to get them on an age-appropriate diet if that's the goal for them based on their overall developmental skills and their sort of neurologic sort of prognosis. But with regard to thickening, kind of general do's and don'ts. We'll talk about this. And then we have adopted sort of the IDSI flow testing method, which has been really helpful for us because it helps us when we teach a family to thicken, regardless of what they use now or as a child grows, they can get the same viscosity. So it's important that we give the parents sort of a tool to use at home. Okay, general considerations. So we attempt always the least restrictive or most age-appropriate diet. Okay, we have to be very careful with infants because of the extra calories that could be added to a thickened feed. Attempt all other strategies first before going to thicken liquids. And then from our standpoint, thickening for pharyngeal dysphagia is typically done after an instrumental evaluation shows that that is the best consistency for the patient. So we typically don't thicken just based on clinical evaluation. That'd be more of an exception rather than the norm, because we have children who actually do worse on thickened feeds. They have more pharyngeal residue and they aspirate the residue after the swallow, or they simply, it's simply aspirate both. They aspirate thin and they aspirate thick. So, and sometimes what happens is that the thicker liquid, maybe the aspiration events aren't as sort of the volume they aspirate might be a little bit less than the thin liquid, so they don't trigger cough. So all the thickened liquid is doing is really sort of masking the signs, as opposed to a thin liquid that maybe they have a little more aspiration event in the airway, and maybe that triggers their cough. So you clinically you see a difference. You're like, oh gosh, he stopped coughing with the nectar when I gave him it clinically, but we're not sure if it's just masking the signs or actually doing what it's supposed to be doing and protecting the airway. So our practice is not to really thicken too much unless we have instrumental evaluation to show that that is an appropriate intervention for the patient. And so we're going to, like I said, we're using the IDSI, which is the International Dysphagia Diet Organization Initiative, and the old terms we used to use are the NDD, the National Dysphagia Diet. So we're stepping away from the National Dysphagia Diet to the IDSI. And the National Dysphagia Diet is the organization or the group, the committee that came up with the terms nectar and honey thick to use as standards when we talked about thickened feeds. And there's a great article, again, talking about this. If you want to read more about it, there's a good article reference right there. Resource. So back with the National Dysphagia Diet, we have thin liquids. And now with the IDSI, we have slightly thick, mildly thick, and moderately thick. And this pink is pretty much what we call nectar in the National Dysphagia Diet. And the yellow is what we call honey thick liquid in the National Dysphagia Diet. And I'm not sure which terms we're using in India, and I'd love to hear about this afterwards. But in the United States, we use nectar thick liquid for the most part and honey thick liquid, but we are moving towards these terms soon. So here's comparison: thin liquid is thin liquid, slightly thick. We don't have one in the National Dysphagia Diet. Sometimes we'll talk about half nectar or a thin nectar, but we don't have technically an equivalent. Nectar is moderately and honey is moderately thick. Okay, so we use a syringe flow test. So all you need is a syringe, 10 ml syringe. You put 10 mLs of the thickened liquid you want in there, and you let it run for 10 seconds. And when it flows, at the end of the 10 seconds, whatever is left in the syringe tells you how thick the liquid is. So for babies, we oftentimes use rice cereal or oatmeal cereal. Sometimes we use some commercial thickeners. But if you use a thickener like rice cereal or oatmeal cereal, what we found is that different amounts are needed to get the liquid thick. So for instance, you might have to add 2 teaspoons of rice cereal to 1 ounce of formula, whereas oatmeal, you may only have to add a teaspoon and a half, but there's great variability. So what happens is if we thicken our liquid and then we test it with the 10-second flow test, it tells us where it is regardless of what you use. Children over 12 months of age, we still can use rice cereal. We can use some fruit puree, or we do have commercial thickeners. And again, I'm interested to see what you're using in India to thicken. So let me just go to the last video, and it shows how to thicken it. Very easy. Hope it plays. I'm trying to unmute it, but I guess it won't. There it is. Can you hear it? Good. So if you want the parent to, if what I tested in the video fluoroscopic swallow study or during the fees, whatever I used, if I used a liquid that was thick and when I tested it before I gave it to the child, it ran to 2 mLs left in the syringe, and then I fed it to the child during the fees, and they did really well on that. I can tell mom, hey, let's get the formula, let's get some rice cereal. Every time you thicken it, run this test and make sure there's 2 mLs left in the syringe at the end of the second flow. Okay, that's really a really easy way to have mom know that regardless of what she uses, whether she chooses rice cereal, or oatmeal, or any other thickening agent, as long as she gets to that 2 mLs left, it's the same thing that we use during the fees or the same thing that we use during the video fluoroscopic swallow study, because you want those to match. And so, like I said, this has been really a great tool for us because we have found that even when we give them what we call a recipe, so 1.5 teaspoons of rice cereal for 1 ounce of formula, even when we give them the recipe and then we test this with this sort of very simple method, those recipes tend to fluctuate. Even if you buy a different brand of rice cereal, so in the US, Beech Nut is a very popular brand, as is Gerber. If you get 1 or 2 teaspoons of the Gerber rice cereal and add it to a formula, and you get 2 teaspoons of, or 5 mLs, I'm sorry, of Beech Nut, and you add it to the formula, you thicken differently because the flakes are different. Beech Nut is very fine, and the Gerber flake is not as fine. So it's just easier to teach this to the parent, and they can sort of use it. And clinically, we use this all the time to make sure that what we're feeding is consistent with what we tested, because that's our goal. If really we're saying this thickness is required in order to keep it out of the airway, we want to make sure that we are thickening it as consistently as possible. Again, we want to move, eventually our goal is to move away from those thickened feeds, but if you have to use them temporarily, you want to make sure that they are as precise as possible. So, and I believe that is the end of my slide. I don't think the next one will run for some reason, but that is the end of my presentation. And thank you so much for listening.
Thank you so much, Christina, for that wonderful talk. You've, I think, covered all the aspects, including the practical tips you've given. I'm sure all of us will benefit from it. I'd like to draw in Dr. Premlata, who's professor in the Chandrasekhar Institute of Speech and Hearing. Dr. Premlata, are you there? Can you unmute Dr. Premlata?
Yeah, here, sir.
Madam, can you just give us a comment or any remarks post these 2 wonderful talks we have had?
Can you repeat, sir?
Can you just offer your comments? I mean, anything, any additional remarks you want to give us?
No, it was an excellent presentation, and whatever the cases I have seen is mainly on developmental disability, not on the infants and neonates. So my experience on fees as well as VFS is limited. So most of the cases what we see here in the institute is children with developmental disabilities, autism spectrum disorders, and other kind of developmental disabilities, children above 3 years. So my experience on infants and neonates is restricted, sir.
Thank you very much. And we also like to draw in Dr. Srikanth. Srikanth, he's a pediatric gastroenterologist. We're going across disciplines now. Srikanth?
Yeah, hi.
Both Dr. Paul's talk, and you can kind of, whatever comments you have, or based on your practice, your understanding of the pediatric dysphagia.
So both were excellent talks, and so ball comes to my court when the oropharyngeal part is actually cleared off. So we mainly deal with esophageal dysmotility, both mechanical as well as the motility aspect of that. Unfortunately, we don't have a fee study for VFSS for a very small children. Probably we are missing on a small proportion of kids who have problems which can be picked up with VFSS. But we go ahead with upper GI contrast study in those children. But we are in the process of setting up that, so then everything will be complementary, and maybe we can do a higher end work for those kids.
Thank you, Srikanth. Any comments? Is Dr. Kishore Sandhu, has he joined us? Okay, so in that case, we'll just move on. I also would like to mention that we have an honored guest, Dr. Mughira Siddiqui from Aga Khan Institute of Medical Sciences from Karachi. Welcome, Dr. Mughira. And thank you for attending our seminars. We'll next go to the experience of a young SLP, Nidya, who's part of our team. She will share her experience of how she evaluates children as far as their dysphagia is concerned, followed by Ajoy Matthew, who is a professor and head in CMC Vellore. He'll also share the Indian experience, and probably with Christina and all here, we can exchange our knowledge and improve our skills. Dr. Nidya, can you come on in? Share screen of Nidya, please. So with any comments till Nidya comes in?
I think Christina covered most of the things we need to know from a speech language pathologist point of view. One of the things which I wanted to comment about thickening is somehow, and Christina can weigh into this, somehow our speech language pathologists think rice is not a great method of thickening because of arsenic concerns. And secondly, the commercial...
Oh, okay. Nidya is starting, I think. So it will continue if you don't...
Yeah, sure.
Okay.
Okay, greetings to all. Yes, sir. Can you hear me, sir?
Yeah, it's all fine.
Yes. So greetings to all. I would like to thank Dr. E.V. Raman for involving me with pediatric dysphagia and the rehabilitation. So move on to the case presentation. I have mentioned it as challenges in pediatric swallowing is mainly because it's been 2 years since I've been into this field, and we have not expertised with this field, but we are learning a lot with each and every case which is coming into the hospital. So the clinical swallow, before I present the case presentations, I would like to present the hierarchy or the, the hierarchy in what we do with the clinical assessment and management. So we have a structured protocol in which we follow with each and every pediatric cases which come to the hospital. So with the clinical assessment, so first we check for the oromotor and so swallowing evaluation, where we take a detailed history, especially the feeding history and the birth history. So in the feeding history, we get to know the child's breastfeeding and how the child has been taking the milk or the food. Is there any choke, cough, etc. Then we do a detailed physical examination, develop assessment mainly with the motor and the speech milestones. Then we do assessment for respiratory status along with the ENT team. Then we determine the oral readiness of the child. We see if the child is able to move on for a swallow evaluation by checking for the non-native sucking in infants and the sucking and swallowing in pediatrics. Later, we determine the optimal feeding for each and every pediatric case which comes in. So in the physical examination, like how Christina ma'am had mentioned, it's almost the same. So we do a detailed pre-feeding examination where we check for the child's alertness, the muscle tone, movement patterns, airway status, communication and drooling. And in infants, we check for the non-nutritive sucking. We check for the reflexes around the mouth, rooting reflexes, and the sucking by just placing the little finger. The strength of the sucking is also being identified. Then when we move on to the swallowing, we check for the protective mechanism. That is the dry swallow. Dry swallow as in we try to initiate a swallow reflex by placing a pinch of salt or honey or whatever is available at the site. Then we check for the cough by the gag. For the cough, we check for the effort of the cough and see if there's any wet cough, gurgly voice with the cough. Then we do a detailed cerebral mechanism examination where we check for the movements of the articulators. We check for the lips, tongue, soft palate, mandible in detail, depending on the child's cooperation. So the swallowing assessment is done with different consistencies of food. Basically, we start with a thickened consistency and then we move on to the thin consistency. We check for the suck, swallow, respiratory pattern first in pediatric neonatal cases. Then we check the lip closure, the latch, the spillage, tongue positioning during feed, elevation of the larynx. Then there's any nasopharyngeal reflux, respiratory pattern, and the cough. So once all these clinical assessments done, then we discuss with our ENT team and we move on to the instrumental analysis, where in our hospital we do phase. The management. So how the management goes on in our hospital is that we follow the WHO ICF framework. So the treatment options which is there for pediatric is mainly postural and positioning techniques, oromotor treatment, sensory stimulation, feeding strategies, diet, texture modification, maneuvers, behavioral. This is equipments and utensils, the different kind of utensils. And then last is the tube feeding option. Postural and positioning techniques is mainly used for the pediatric population because it's very difficult to make them follow a manual. The easiest thing which we can do is the chin tuck, the chin down positioning is a little helpful in the pediatric population and the others. The oromotor treatment is mainly for the oral phase, especially with children with developmental delays and palsies and etc. So we work at the level of the lips, jaw, pharynx, tongue, soft lid in a very playful manner so that the child does the oromotor stimulations. Next, moving on to the measure of food consistency. So we follow the national diet, dysphagia diet. So there are 4 levels of dysphagia diet. The first is the diet pureed form. It's mainly like the pudding texture. So when it comes to the Indian population, pudding is not being understood by many of the people who come in. So we tell them, we call it as kanji. I don't know if you all know it. It's called kanji. It's the rice porridge. So the rice porridge can be altered into different consistencies. It can be thick and it can also be thin. So we ask them to make it in a pureed or a thickened format. Mainly we ask them to make it as a thickened liquid, thickened pureed, a very thick liquid of kanji, rice. It could be of different millets, even ragi and rava, suji. So we ask them to do it because this is the main diet which we follow in everyday life. Yes. Then level 2 is mechanically altered. It's called a semi-solid, where there's only a little bit of chewing ability which is required. So we churn the food, rice again. It could be rice. It could be, India has a lot of variety of food. So with whatever food they have, they get it churn format. So it could be vegetables, it could be payasam, and many things at their ease. What is easy for the patient or the parents, they get that and come. And the level 3 is the advanced food diet, which is more of this idli, dosa, or things like that. And the regular food. Regular food is where the child is able to chew on to a cookie, biscuit, chapati, or roti, and things like that. So moving on to the clinical scenarios, that's the case presentation. Now we have taken a child who's 2.10 years. So this child has been diagnosed with Peary-Robinson syndrome and is tracheostomies. The child has left facial palsy and is also been repaired for the cleft. So this child was, a direct laryngoscopy was done, and the child was being diagnosed as having suprastomal granuloma, which was excised. And the child was referred for swallowing, mainly because the child was in the NG tube since birth. So again, we started with the pre-feeding examination, like how I mentioned. So right swallow, this laryngeal elevation was fair because the child was not on constant swallowing stimulation or on constant oral feed. The cough effort was fair, and with the oral examination, the child could retract, protrude, lateralize the tongue, elevate. All this was done with different taste textures. The palate was again bilaterally repaired. and the cure is nothing here. Vegetative skills, the child the child had a lot of difficulty with blowing and sucking, and we are still working on it. So the instrumental analysis was fees was done in the hospital. I'll just play the video of it. So here the fees was done with the ENT team. And two types of consistencies were used. One is the pureed form of rice and a thin liquid, which was cut. So 5 ml of the food of the pureed form of rice was given first. And I'm sorry for the bad, not a very good quality of the video. Yes. And you can see the child could swallow it, but it is cleared only after the second swallow. And we can still see the bolus remaining. Yeah. And then the next, cleared after the second. So the child has to swallow twice to clear it. And still there is a little bit of remains. And the next swallow. So now we started, there is the liquid swallow, and you can see that the liquid is being aspirated. You can see it going towards the subglottic region. Also, the movement of the vocal cord is restricted. If you could see. But there is aspiration, which you could see. And when we were doing the video, we could hear the gurgly voice, and it's choking on the liquid technically. Then the child was on swallow rehabilitation. We started with the oromotor stimulation just to enhance the dry swallowing for a few weeks. And then slowly we initiated with feeding. That was, we started with pureed food with the right positioning and pacing technique where little by little the food was given. This was done under an SLP supervision. And the child had repeated sessions in the hospital. And slowly we had to start with the oral feed at home, and the NG tube was calibrated according to the oral intake. Liquids were started only later when the child achieved good oral feeding of the pureed or the thickened soft diet. Liquid feeding also was done in pacing method. First started with spoon feed, and then we started with the sipper and a very small glass or a tumbler. Then the tube was removed recently, and presently the child is on oral feeds with the regular diet. When it comes to the speech and language evaluation, the child is able to follow 2-step commands, listens to a step story, step sequences, vocalizes, and utters monosyllabic and bisyllabic word. There is a delay with this receptive and expressive language, which is being intervened, rehabilitated. Moving on to the second case. So this is another child, 2.3-year-old male. Had come with a complaint of cough with thickened liquids and choking with liquids. There was more of cough with liquids. And swallow assessment was done and swallow assessment was done and directed to the ENT team, where they did a direct laryngoscopy and was diagnosed as 2 laryngeal cleft. So the child was repaired for the cleft and again was referred for swallow assessment and rehabilitation later. So the pre-feeding examination, child with good effort of cough and bilateral gag present. With respect to the OPMB, the child had normal structural and physical structures of the articulators. So the fees was done for this child, and with liquids we could see that the child had penetration and aspiration. The swallowing is pre-surgery. We had tried to do a little bit of pacing because the child was not on Ryle's tube or any other tube feeding. The child was on oral feed since birth. But only thing there was this cough and episodes of pneumonia, I mentioned. Okay. So pre-surgery, there was not much of an improvement with pacing and positioning. And after the child was after the child had undergone surgery, child could tolerate the thickened liquids and the thin liquids. There was no cough, and there was only occasional cough when the child had taken in large amounts. So the child used to take the bottle and just take a big amount when the parents are not around. So he used to cough at the time. Presently, the child is managed with the SIM and he has age-appropriate speech and language skills. I'll just play a video of his pre and post swallowing before the surgery and after the surgery. So during the pre-op assessment, you can see here. Every spoon, the child had a cough. And this is post cleft repair. So the mother was taught to give it a small bit, and there was no cough. The end of the case presentation.
Thank you, Nadia, for that nice presentation. We draw Christina now for her comments, and we'll wait for Dr. Ajay's presentation. Will be following that. Christina, around?
Yes. So did you have a question earlier?
No, just your comments.
Yes, it's nice to see that we have so much in consistently, and we're doing things the same. Our clinical evaluations seem very similar. Some of our therapy seems very similar, so that's great to see. I'm actually interested in back to something that Sohit said with regard to thickening. I see you do thicken liquids. What do you all use in India to thicken? Do you use cereals? Do you use what is your preferred method if you have one?
No, ma'am, we don't. We do have thickeners in India, but people don't afford much for the thickener because they prefer to bring it from homemade, and they get it appropriately. They get it the way we ask them to get it. So we don't have much of a problem. We do have thickeners of the hospital, so we use the immediate Nestle thickeners in case of emergency. Otherwise, they do bring the best out of it.
Yeah. So you thicken naturally with home products.
Yes.
Yeah. And that's what's so great about that syringe test is that, regardless of what you use, whether your family chooses, some puree vegetable or puree fruit to add to it, as it's the syringe test can let you, it implies or gives you flexibility. And so you can, as long as it's thick, the thickness you want, that's great. We struggle, I guess, a bit, birth to 12 months, I try really, really hard not to thicken. We try to avoid thickening as much as we possibly can. When we have to, when our hands are tied, we give the families the option. And I lean a lot on my GI doctor as to, okay, for this 2-month-old, what do you think especially from a gut standpoint, or, what would be the best? If they do have baseline gut intestinal issues, we really, really try to really hesitate to thicken, but I lean on my GI doctors to help me a lot back to the team approach as to what is the best approach for this infant. Birth to 12 months in the U.S., we really stay away from any kind of artificial thickener as best as possible. But we also have some concerns about other thickening agents, oatmeal or cereal, they constipate, the arsenic, what's going on. So it's more complicated than it seems. But yeah, there is no clear answer. But I think working as a team with your ENT, your GI doctor, to see with the family, with their choices, what the best route is kind of how we approach things.
Christina, do you also believe in arsenic related to rice thickening?
I know there's articles out there on that. We don't not use it. We really leave it up to the family, and we talk to my GI doctor. What do you think? That kind of thing. And so if families want oatmeal, we use oatmeal. It's just kind of varies. Some as the kids get a little older and they're drinking like maybe 8-9 months, some juices. Sometimes we'll put like pureed carrot into the juice to make it a natural, almost like a smoothie drink. And as long as we have that syringe test and mom tests it and it comes out to whatever level we told her to, you know, she's comfortable doing that. So, you know, and with gel mix, that Caribbean gel mix that we sometimes now is kind of in the market as well. Talk to my GI doctors. What do you think? Which one is the best fit for this patient? Especially if we're on the aerodynamic team, that's the beauty of having that team. We consult with them. What is the best fit for this patient? So we go from there. I can tell you in the really high risk infants, like the preterm infants, NICU or cardiac, I mean, the NICU in this year, 2020, I have not had one baby on thickened feeds. We try everything we can to not put them on thickened feeds. Those slow nipples, pacing. I know the therapist said pacing, positioning, everything we can to keep them off those thickened feeds. But once they're 5, 6, 7 months, you know, they're a little older, they're taking purees anyway, you know, it's maybe a little bit more flexible, but those first 3 or 4 months, I definitely lean on my GI doctor to give us some tips and advice of what he thinks with regard to what's the best fit for this baby.
Lydia has been a very important member of the team, and I really acknowledge your contribution in this area. Paul, any remarks?
I just think it's important to remember that when you are thickening, that's not the end point.
Yes.
It's a means to get you someplace else. You can slow the kids down to work on oral motor skills to improve. So we've seen a lot of kids coming in on thickened material and they've been on it for years. And it's easy to just leave them there, but it's not the end point.
Yeah, it's definitely something that if it has to be used, okay. But it's like, how can I get them off it? What are we doing in therapy? What are we doing? What tools are we working towards to get them off it? But I don't know if you're using rice cereal, Paul, at Cincinnati Children's or oatmeal, or if y'all use a hodgepodge, you know.
It's very similar to yours. You know, what does the family want? We like to use the natural agents, but we just use whatever.
Yeah.
Thank you.
I find that my GI doctors are very helpful with that. After 12, 15 months, we can go the commercial route if, again, GI doctors give us clearance and there's no intestinal or gut issues in the child's history.
Shrikant, any comments?
Yeah, I agree with that, because even we also have the same issues, not pertaining to the oropharyngeal dysphagias, but if you have reflux issues and if you have to try a non-pharmacological management. So this is one area we try with all other anti-reflux measures, then we go for that. But like if they are beyond 3 to 4 months, sometimes we can use a bit of rice powder or rice porridge, which has been tried with individual discussion. I know it is not a standard practice, but when we are left out of options, we have tried that once in a while. Beyond 6 months, then there is no issue. Because once they're going for weaning, then we can use all home-based products which can be graded into various consistencies where child can tolerate. But the younger age is always a problem.
Thank you, Shrikant. I also want to mention we have an honored guest, Dr. Yasavardhani from Sri Lanka. We're trying to spread this beyond India, Pakistan, Bangladesh, Nepal. We have representatives from those countries. We have similar problems, and I think we should share our experience. That way we are getting to be crossing borders. Thank you very much. So I think we'll go to the next presentation. Ajay, who's another wonderful resource person, our airway group. Ajay Matthew-Verghese is the head of the Department of Pediatric Otolaryngology in a very prestigious institution, Christian Medical College, Vellore. And I request Ajay to share his experience with us.
Thanks, Raman, and thanks, Prahlad, for having me. So we had an excellent talk by Paul and Christina. This is more tuned to people who are just getting into dysphagia and pediatric dysphagia in particular. There are excellent resources, especially by Paul, who's written so many articles, and those are actually useful for us to start off. So to start off with, pediatric dysphagia is a significant problem. If you look at children who are developing, around 45 to 50% of normal children have some sort of feeding problem in their life. And if you look at patients with development delay, it becomes even more. The estimates vary based on the population which is sampled, on what type of impairment or how it is defined, and the choice of assessment methods. So it is not an uncommon problem. But when it comes to India, this is one, I was trying to see articles which are there in India on dysphagia. And this is one by Krishnan. It was published in 2018. And this is not on children. This is basically the whole of dysphagia research that happened in India. And there are only about 64 articles. And these are also not PubMed index. These are all the articles. Mainly these are from RK resources that he's found articles. And so it's a very less number of publications or research that is going on dysphagia in India. And if you look at pediatric dysphagia, I could only find one article. This is by the Amrita group, by Jayanti and Jayakumar, where this was a study done from 2013 to 15, their series of 88 children and their results which are there. So if you look at India, pediatric dysphagia is definitely in its baby steps. And so that is why I thought I'll do this presentation. So I'm just trying to highlight 5 points. I'm not going to go into details of how to evaluate because that's already been discussed and it's been a good presentation by Paul and Christina. The first thing that we need is a team approach. So if you look at the same article by Krishnan, you see that of the, there has been an increase in publication from 2008-9 onwards, but there has always been single publications by either a medical team or a speech pathologist team, and there has not been a lot of multidisciplinary involvement. So I think that is the first thing that we need. So I think we need to build teams, especially ENT and speech language pathologists need to get together and form a team, and I think we can move much more forwards with it. There are various challenges. The etiologies are different and most often not well defined. Development and growth are changing with as the child is growing. So we're looking at a moving target, and children are not young adults. So going on to clinical evaluation forms the foundation of diagnosis. It determines the need for instrumental evaluation and also helps to formulate a management plan. So the second point that I want to highlight is that we need to have a conducive environment. We need to have an environment where the child feels that he is like at home. Because if you're trying to feed a child and if the environment does not look very friendly, there's a good chance that he is not going, or you are going to get a good history and examination. So as you're examining or taking a history exam and then doing a clinical feeding evaluation, you need to look at the diagnosis in terms of whether it's a feeding problem or a swallowing problem. You need to look at whether there are medical and developmental concerns, whether it's an acute or a chronic problem, and whether it's stable or it's progressive. And so as you're going on to look at it, you need to first differentiate between whether it is a feeding problem or a swallowing problem. So if the parent is complaining that the child is taking a long time to eat, or is refusing certain kinds of food, or is dependent on others to feed, or if the parents just say that the mealtime is stressful, they're more likely to have a feeding problem. Whereas you heard about the suck, swallow, breathe coordination. So if there is incoordination, or if they complain of recurrent pneumonias or aspiration, or the child has got a wet gurgly sound or stridor, then you have to think of a swallowing disorder. Failure to thrive, vomiting are likely to be there in both. So the third point that I want to highlight is that although there can be overlap between the two, you have to differentiate between a feeding problem and a swallowing problem. Then you go on to your assessment. We have already heard about the pre-feeding assessment and the general examination. So I'm not going to dwell on that. And then come to the next point, which is the clinical feeding evaluation. So as ENT, we don't normally do this, but I would urge anybody who is actually interested in helping children with dysphagia to do a full feeding evaluation. So this is not just giving little bit of water and looking at how the child is managing, but to look at what the child normally takes. So if the child, whatever the child is taking at home, whatever the child is doing at home, try to replicate in the office, and then you will be able to identify. So this is a 7-year-old child who came, who had a history of having typhoid at 6 months of age, was in CU for some time, and after that has been fed on liquids only. And you can see, like, even with a little thickened consistency, all he's doing, he's spitting it out. So that will give you an idea that this is basically a picky eater who is deciding what he likes to eat rather than a swallowing problem. This is an 11-year-old boy with cerebral palsy who is just able to sit with support. And you can see that he's keeping the food in his mouth. There is no closure of the mouth. He takes time to swallow. His oromotor skills is poor. So these are things where you are more likely to have a feeding problem than a swallowing problem, although they can be associated with. If you contrast that to this kid, this is a 9-year-old who was otherwise well child, had encephalitis and was admitted in ICU for about 10 days and had regression. So right now he can just about sit with support, and he's got an NG tube, and they have come for a referral to try and see if we can remove the NG tube. And you can see as soon as the child has started to some feed, he's starting to have a cough. So that is suggestive of a likelihood of having aspiration. So if you have a child who has got a cough, who's got a wet gurgly sound, or who has got respiratory distress or evidence of respiratory distress on taking food, then you have to think of that the child is at risk of aspiration. Now, although clinical feeding evaluation is not ideal for evaluating a child with silent aspiration, it gives a significant good value in terms of specificity and sensitivity, about 60 to 70% of sensitivity and a little higher specificity. And even auscultation along with oropharyngeal while feeding will give you a idea of whether the child is aspirating. This is definitely not the best way to evaluate a child, but it gives you so much of information that will guide you further. And then going on to instrumental evaluation. If you have video fluoroscopy options, then you can do it. It gives you a lot of information. As you heard from Christina, it is very, very useful looking at all phases, oral phase, oropharyngeal phase, and esophageal phase. But when you are starting off, it is very difficult to get a option of doing video fluoroscopic study. Whereas coming to fees, it is much more common, and it can be done like you do your flexible endoscopy in your outpatient service. So if you have the speech therapist who is with you, you can actually try giving different consistencies and then look at evaluation of solo. So as you don't ideally, you don't see the solo as such, you will see the pharynx before the solo and after the solo, and you get a whiteboard while you're doing the solo, as Dr. Paul had said. But in children, sometimes you can see a little bit of food in the vallicula as the child is soloing, which is normal. So as you're doing fees, what do you look at? You look at first you look at the structure and the dynamic function. So you're looking at whether there's any abnormality, what's the cord movement. And you can see here that this baby has got a vallicular cyst. So if you have a child with aspiration, you should look for laryngeal cleft, which is a little difficult to see on a flexiscopy, but if there's bunging on the posterior part, you can suspect that. And other findings like in this child where you have a valvular assist. The next thing is to look at how the child is managing normal secretions. Now, if you see this video, you can see that the child has got a lot of his own secretions in the oropharynx and in the hypopharynx, and that is also spilling over into the larynx. So this child is definitely not a child who is safe to swallow. The other thing that you can see as you give something in the mouth is whether there is a premature spillover. So you can see that in this child, as soon as the child is given something, that spills over through the valvula onto the piriform fossa, and then the swallow is initiated. So that shows that there is premature spillover. Sometimes, like when you have a pathology, like this is the same child who had the valvular assist, you can see that in spite of swallow, there is still some residue which is there in the valvular. So just because you see an anatomical pathology, it is not necessary that you can exclude that pathology, I mean a feeding problem. So you really need to look at fees also along with that. You may also see residue is there in the pharynx after the swallow. And you can also see pooling, and sometimes even the pooling which is spilling over into the larynx. If it stays above the level of the vocal cord, it is penetration, and as it goes below the cords, it is aspiration. So these are easy things for us as ENT to evaluate. And so I just want to leave with those 5 points. Like, so for all the people or the ENT doctors who have actually thought of starting off practice in pediatric dysphagia, 5 basic steps. Have a team, good speech language pathologists, form a team, and then you can have other inputs from neuro, from pediatrics, from developmental pediatrics, from gastro as the need comes in. Create a conducive environment for evaluating the child, differentiate feeding and swallowing problems, do a good full clinical feeding evaluation, which gives a goldmine of information. And FEES is a good, reliable tool that can help in evaluating pediatric dysphagia. Thank you.
Thank you, Ajay. I mean, you really did justice summing up everything and then trying to enthuse youngsters or people in pediatric otolaryngology departments to start their own swallow clinics. And inspired by the work of Paul, of course, pioneering work. And we have Jayanti in our audience, I think. It was her paper you were alluding to. Jayanti, are you around? Can you unmute Jayanti? Jayanti Pavitran?
She's here only.
Yeah, Jayanti, unmute. Prahlad, can you unmute Jayanti?
Yes, sir.
Yes, sir. Yes, sir.
She's unmuted. Yeah.
Jayanti, can you tell us about your study? I think at least from this country, it's been a pioneering study. We want you to say a few things.
Good work there because they've got a good center there. So,
Actually, sir, I have to identify the risk factors for pneumonia because it's always a concern. A dysphagic child, where this child is at risk for pneumonia. So it's a retrospective study.
Oh.
So.
Wonderful. I mean, it's good that people, youngsters like you, are doing some kind of a study and publishing it. It's woefully inadequate studies on pediatric swallowing. So, congratulations. We are honored to have you as a guest here today. I mean, as a member of the audience today.
Thank you, sir. Thank you.
Hopefully, next session you'll be giving a nice keynote address. So, thank you. Now we need to go to various. Any questions that we have, we need to go through that. Before that, comments from our panelists once again. Paul, anything you'd like to say?
I guess there's 4 points I'd like to make in listening to the previous talks. FEES has a limitation of being able to see what happens during that white out. And it becomes most evident during chain swallowing. And it's just important to kind of keep in mind what the clinical situation of the child coming in was and you explain that clinical situation. If you have a child with repeated bouts of pneumonia, recurring respiratory infections, and your fees looks normal, but the child is chain swallowing, it's very, very easy to miss aspiration during those chain swallow events. So those kids, you often have to get the video fluoroscopic swallow study to see what happens during the act of swallowing. We can get lulled into a false sense of everything is normal, and you just have to be careful of that. Second thing is, on both the video fluoroscopic swallow study and fees, we define a lot of abnormalities that we see. We see a lot of residue. We see a lot of premature spillage. And it's why the child is having those different findings will let you develop the treatment program to take care of it. It's not just define what you see. Also, as otolaryngologists, we understand the anatomy, understand the functional aspects of swallowing, but we don't know what to do to fix it. And that's why it's so important to get a good relationship with a speech language pathologist with an interest in dysphagia. They're the ones who can develop the treatment program. They're the ones who can help the child get over this particular problem. As ENTs, we can define the problem, but we're not going to be able to fix it. Just remember, coming up with a functional swallow is often the goal. It doesn't have to be normal. It just has to be a safe swallow. And that's where your therapists are so vital in your program.
Thank you. Deepak, any quick comments?
Yeah, so on the same lines Paul said, the other way as well is important. Just because you see aspiration doesn't mean the kid is aspirating. So you need to take the whole clinical picture. It's just a shot in the swallowing. So you might have just one time the kid is crying or doing something else and is aspirating. Don't take such that this kid is aspirating if the kid is otherwise doing well. So you need to take it in perspective of what's happening clinically. The other thing is, when you're developing a program, try to educate people around you. So once you have some cases, show it to some of the pediatrician around, because those are the ones which see these patients and send them to you. Once they see some case made an impact, then automatically these patients starts coming to you, and you'll start to make a difference.
Srikanth, what about these milk scans for reflux? Do you use them? When do you use them?
Milk cans?
The scans for the radioactive.
Yeah, so we don't like, this is specifically to look at the reflux, gastroesophageal reflux disease. So as per standard protocol, so we go with the therapeutic trial, and if they don't improve, then we go with the evaluation. So if in that, the gold standard is pH impedance if you're looking for gastroesophageal reflux disease, that if you're planning for investigation. So the sensitivity of milk scan and also the contrast esophagogram looking at the reflux is not that high. So they're not the standard ones for GERD. So it is not recommended upfront. But in the centers where there are no options of pH studies, then probably those things can be undertaken, and also to exclude other causes for symptoms like tracheoesophageal fistula or aspiration and that kind of things.
Typically, post laryngeal reconstruction, there are various procedures. Are there any particular procedure which is more at risk for causing aspiration versus the others? Sohit?
Yeah, absolutely. I think that's a great point, and you brought up, Dr. Raman, is these kids before undergoing an open airway procedure will have a detailed swallowing evaluation. And we all know one of the procedures which is high prone to causing aspiration is a posterior triquetral grafting, and all these kids, depending upon the amount of distraction you're using, will end up with some sort of aspiration problems. So it's very, very essential whenever you go in for an recon in any child to have a detailed evaluation pre-op as well as post-op. And by detail, I mean getting both of these as well as a VFSS done, as well as getting a speech language involved in those care. So all the complex airway procedures, I would even say most commonly is the posterior cricoid split, as I mentioned, anterior posterior grafts, cricotracheal resection, anything in which you are doing some larynx. Of course, there's going to be a high risk. And as we always teach the parents, it's always a balance between airway, voice, and swallowing whenever you're doing an open airway recon. And you might or gain one function, and then we might have to compromise on some third function. Maybe it's voice, maybe it's aspiration. So yeah, I think there are surgeries like the split, which are grafting, which are prone to increase aspiration, and all these kids need to get speech language pathology evaluation.
Right. Anybody in the audience who wants a question?
Can I make some comments if you don't mind?
Please.
Most of the time what we do is that the kind of cases we see, we don't have a standardized protocol, particularly in India. It varies from institution to institution and hospital. We need to have a standardized protocol to assess the feeding and swallowing problem. As Dr. Ajay mentioned very clearly, that feeding and swallowing needs to be differentiated. Then only we are going to get information from the parents as well as from the observing the child regarding their feeding and swallowing issues.
Thank you, madam. Is Dr. Yasavardhani from Sri Lanka? Okay, Ajay, any other comments that you have? If nobody from the audience has, Dr. Kailesh Pujari?
Shrikant wants to say something.
Shrikant, yeah, go ahead, Shrikant.
It's
open house now.
So when like ma'am was mentioning, like we have to differentiate between the feeding issue and swallowing issue. At the same breath, I would say that we have to differentiate between oropharyngeal and esophageal, because the set of investigations which come for esophageal dysphagias are entirely different. So it should be a very astute clinical examination and differentiation, like into which category child falls in, which we can do, like in centers like us, we are able to do that. So the child can be prevented from unnecessary investigations. So if it is a oropharyngeal, then it goes to the ENT folks, and otherwise it comes to a GI. So depending upon it, because there is a long list of with pertaining to esophagus, starting from infancy to older children. Like one common problem which we see is reflux, in that one of the symptom can be just food refusal or arching. So to differentiate, because the management is entirely different. So similarly, we have other modalities for esophageal problems as well.
I think that's the advantage of the center that we have. By default, are designed this group. So I think that's kind of sorted out thanks to Shrikant being an active member. Any problem, we always reach across to him, and hopefully it's vice versa. So,
sir, one more thing what says that apart from the structural, mechanical, or neurogenic cause for feeding and swallowing problems, we do have seen the children with a lot of behavioral issues having a feeding problems and swallowing problems. First and foremost, important is to what is the cause? Is it a behavioral, or is it structural, or functional, or is it neurogenic? Based on that, our treatment strategies also will vary. That also we have to keep it in mind while doing the treatment.
Yeah, very true. I think Dr. Paul also alluded to that, and I'm glad that's an important thing we keep in mind. Ajay, any remarks?
Yeah, I think we should have coordination. I think that is, something lacking, because we have speech therapy institutes, we have medical institutes, we have medical professionals separate from speech language. And so I think that is the biggest problem in India, I think. So if you look at all the publications, at least in that article that was there, all about like ENT has done, or physician has done his written about, whereas the speech language pathologist writes about their part. So there is no coordination. Like I think Dr. Deepak said, it's only when we talk to each other, I think people get to know, and then it gets. So I think we need a lot more cooperation to happen, and even between institutes to have a sort of understanding of how to thicken, or any of those, how to evaluate and have a protocol that will help.
So today's webinar probably one step in that direction. Let's hope for the best. We've been trying to improve ourselves for the last so many years, so hopefully this will be a major step on that. Deepak, any final comment before we close the session? Any questions from the audience? Once more, I think most of the questions have been answered in the chat box. But Deepak, anything?
I wanted to give a shout out to a meeting happening very soon. This will be the one of the meetings where the most number of global experts are coming together, pediatric airway experts. The meeting will be October 9th, 10th, and October 23rd, 24th, and it'll cover pretty much all airway topics, and the best of the best will be there. So, and the most important thing is there will be a fee, but the money, the registration fee, everything will go towards helping the poor patients get their airway surgery. So, yeah, one, it is a big educational event, but also it is a very big charitable event as well.
Thank you, Deepak. I think we'll circulate your the final one. We'll circulate it amongst ourselves, and of course, it will be disseminated through email and through WhatsApp groups.
Sir, excuse me.
Prahlad, sorry.
Sir, this is Zainab here. Can I have a question, please, sir? Can I?
Yeah, please.
Yes, sir. Sir, honestly, I really liked the webinar and kept me glued to my, system all evening. I would just want you all to throw some light on bedside examination for dysphagia in children and how it differs from what, the extensive examination that we were discussing in this procedure. So is there anything that we must do? Is it a short way of, screening? Can you please throw some light on that?
So Deepak or Sohit, you want to say something?
Yeah, so when you do a bedside eval, typically for us, either we do it in conjunction with SLPs, or the SLPs do, and then give us a brief, and then we go examine together. So say, for example, it's an infant. So when you're looking at the infant, you're looking at if they're breastfeeding, how's the latch, is there an overflow, what's the pacing of the swallow, what happens during that? Because if the breast is engorged and there is the feeding happens too fast, then the kid might be aspirating. That doesn't, so you that picture in place. On a different level, say a 2-year-old comes to you and is having coughing and choking with feed. So you can do your initial evaluation where you can give typically whatever they give that and see what happens with it. And that will give you a lot of clue on what's happening, because if say the child is swallowing and is very gurgly at the end of the swallowing, probably the kid is aspirating. And that way you move forward to doing further assessment. If you see that there is a lot of it is only behavioral issues, then it doesn't need the full workup. Then you start working towards address those behavioral issues.
Christina, your comments on the question? Are you around? Christina?
I'm here. Yes. Yeah. So adding to what Dr. Mehta said, and taking a sort of developmental approach as well. Infants to toddlers, what do you expect? Certainly after the age of 2.5, 3. By 3, they should be sort of chewing and cup drinking. All of these things should be age appropriate. So having a developmental lens is very appropriate, very important. And then taking sort of a global picture as well, just because you don't see something, but if they've had recurrent respiratory infections and no one's been able to figure out why. Sometimes we'll see kids who have a diagnosis of asthma, and it turns out maybe not asthma, and so that uncontrolled. And so using a team approach, talking to pulmonology, GI, ENT, speech together to see whether or not that patient requires further assessment of basic airway protection. A clinical can't give you, but a clinical does give you very good information about the oral phase and the overall dynamics of eating with the family and what the child accepts and doesn't accept. And if anything, it prepares you for an instrumental. So they only take a certain bottle or a certain cup. And so you're prepared for your instrumental exam based on what you've seen clinically.
All your comments, bedside, will you decide what tests to do? And
you get that adult feel. You talk to the family to get some idea of how time critical this problem is, how significant it is. We see a lot of kids that come in and have some nuisance problems. I mean, the child doesn't feed easily, but they're gaining weight well, the family can adjust to it. Then there's the other side of that coin where the child is having significant medical issues. So getting the right framework as far as how aggressive and how quickly do I need to move is important. And you can get that really from the history just by looking at the child. And then your initial assessment just lets you know how concerned am I for a structural problem? Do we need to go to the OR before we do anything else? Or is this something that therapy needs to start working on? And it's important also to remember that you come up with your initial plan, then you reevaluate it. Not working out right, you then go back and revisit the problem and adjust your plan accordingly. We often get it wrong, and you just have to be honest with the family. This is where we're not making progress. We're going to go down a different track. But you have to start someplace. And I think as a physician, we have to give support to our speech language pathologists who are really the front line. They're the ones working with the kids, don't want to hurt the child. So, you know, we need to push them or they'll never be able to move forward. But if we push too hard, they sometimes can fall back. So it's important just to reevaluate and be willing to adjust and work. We're going to try something else.
And I want to mention something real quickly too with regard to clinical. Sometimes we get the impression that a child does need instrumental evaluation, video smallest or fees, but sometimes we have to work with the child before that. So prep them for the eval. So children who've had NG tubes or G tubes and really have had minimal by mouth, we have to work with them and prep them a little bit to get them ready for the procedure. So if we do a fees swallow and they won't even open their mouth, or we struggled with them so much in the clinical to get some swallows, to get them accept the consistency or a liquid or a puree, it's probably going to be even harder in the video fluoroscopic suite or in that fees chair. So, but we can't, if we're concerned, we can't give them so much. We can't go on for weeks and weeks and months, but enough to get a better feel for the child and just to get them compliant for the exam and to get the best results we can. So a clinical or a short term of therapy to prep them for their instrumental sometimes is used.
Thank you, Christina. You've earned an invite to our next pediatric swallowing update. Let's hope COVID disappears fast. And Paul assures me that it's going to disappear on January 15th. And when Prahlad asked him which year, he refused to tell us. So let's hope for the best. And thank all of you. And thank you, Zainab, for asking that question. You had multiple responses. Hope they answered your query.
Yes, sir. Thank you so much.
Welcome.
Thank you so much.
Welcome. And we need to thank, apart from the wonderful speakers and the panelists and the our SLP specialists who joined us, apart from Dr. Ajay also telling us what's happening in his institution. So we need to thank Dr. Prahlad. Prahlad, take a bow for offering.
Thank you very much, sir. I must, great event, audience really enjoyed. We have a very good audience coming in almost about 12 countries today. That's really good. Yeah, thank you very much. Really honored to have you.
On YouTube. So please, whoever hasn't seen your friends or you want to see it again, please go ahead. Thank you very much. And good night, good morning, or good afternoon, depending on the place of the world you're in. Thank you so much.